Good afternoon, everyone. Thanks so much for joining our Define quarterly webinar series. I see folks are still connecting to audio here. Give folks a minute to hop on. Well, it's really my pleasure to introduce our speaker today, Dr. Allison Dempsey. Dr. Dempsey is an associate professor of psychiatry at the University of Colorado School of Medicine. She's also the director of the Connections Program for High-Risk Infants and Families and the director of program evaluation for the Department of Psychiatry, Women's Behavioral Health and Wellness. She wears many hats on our campus as well as through our state, and really has been a tireless advocate for supporting the mental health needs of our families here in Colorado. And today she'll be presenting to us a topic that's near and dear to many of our hearts that are doing this work, focused on family-based mental health services for high-risk infants. So thank you, Allison, so much for joining us.
Thank you so much. And although I am speaking, I'm speaking about work done by a tireless group of clinicians and staff who have been, and partners who have been incredibly helpful in the past few years setting this up. And a huge shout out to my co-presenter, even though I'm doing most of the talking, Dr. Jessalyn Kelleher, who's our Associate Director of Clinical Services for our program as well. So many of you may be familiar with our Connections program, but it has now been in existence for about 3 years. We really launched in about February of 2020 in its current form and then have expanded a bit over time to the point where now I believe we have 6 psychologists, a psychiatrist, and a lot of support staff who help make this happen. And so we wanted to give an overview on some of the things that we do, what we're looking to do in the future, how we can partner with others, and then also how individuals who are working in NICUs across the state can really think about how to provide family-based mental health services, either with through partnering with psychology and other mental health provider teams, and in the direct provision of services within their own NICU with the current staff. So broadly, our Connections program is a program that's based in the University of Colorado Department of Psychiatry, although we practice in a few different locations. We provide what we call conception to kindergarten care. So we focus on high-risk infants and their families really across the early childhood spectrum, which in our view starts during pregnancy and goes up until about age 5 or 6 years when they transition into more formal schooling. We believe that it's absolutely critical to provide services and meet these families where they're at, so across settings. And our overall goal is to facilitate connections critical to infant mental health and development over time. My slides are not progressing. Okay, there. So I have a few learning objectives for today. First, you can read these yourselves, but I like to just bold the terms that I really want to call out here. So we're going to be talking about how family variables affect the health and well-being of the infant. So they do not exist infants do not grow up in a bubble. What's happening around them and the way that we work with families really affects both their medical outcomes and their psychological and developmental outcomes. I like to describe, or have you be able to describe some various psychological interventions that can be used in various sites of care, identify different strategies that you can use for family engagement, and then also hopefully walk away from here with a plan for, or ability to develop a plan for connecting families in Colorado NICUs with needed supports. I have no relevant disclosures to make, and we won't be discussing any unapproved products or off-label products. Okay, so the first thing I wanted to point out is when we're talking about high-risk infants, we're talking about multiple settings. We can talk about obstetric settings, when we see families on an antepartum unit, when we see them in labor and delivery units, fetal care centers, general perinatal settings. We work with families in the NICU. We need to think about how we partner with NICU follow-up programs in the places that these families go for follow-up, even if they're not formal NICU follow-up programs. And then, of course, delivering services in more traditional outpatient mental health settings. So first of all, I want to frame this idea, and I hope others on the call have heard this before, but the idea that really the having a baby born preterm or with medical complications really is a contrast in expectations versus reality. And that is traumatic. That does not mean that families will necessarily develop trauma disorders. They can have things that we call post-traumatic growth. They can learn and grow from these experiences, and they can actually enhance their life over time. But we do need to view this experience as a trauma for families. And so many have this vision of that their delivery is going, or I'm sorry, I skipped ahead 2 slides, or I lost one of my slides. That pregnancy and delivery are going to be really happy. Often people are envisioning maybe delivering in birthing centers or with their doulas present, vaginal deliveries with no complications. And often the reality for high-risk infants is very different. They're very medicalized. They may be rushed back to an OR. There's a lot of uncertainty tied into what's going to happen during the delivery. And instead of maybe getting to do skin to skin with their baby after delivery and having what they really perceive as important bonding moments, the baby instead has to be whisked off to have their own medical care. And often we're also treating the mother at that same time for complications that have happened. And then there's that idea of what happens in infancy. So many have this idea of taking the baby home. Maybe they've set up a nursery. Maybe they haven't even gotten to that point yet, but they've started to consider, what does it look like to have an infant in my life? How many months am I going to take off work to be able to spend with my infant at home? How will my infant engage with his or her siblings and extended family members and friends? Whereas the reality is that often the infant, especially our high-risk infants, aren't going home during that infancy period, or certainly not right away. And instead of a room with a crib and a window and teddy bears everywhere, we're looking more at a room that may or may not have a window, that has a lot of medical equipment in it, and the parents kind of trying to figure out where they even fit sometimes in that room. And then this continues into early childhood. This trauma doesn't end when families are discharged from the NICU. Often they feel like it's going to, and then kind of get home and that reality sets in, that instead of meeting developmental milestones on time, exploring different foods and getting to go to daycare and play with other kids, the early childhood period can be filled with a lot of doctor's appointments, a lot of medical equipment. And some families have said, we don't really go on vacation, we just kind of relocate where we're at, because they have to bring everything with them. They don't actually get a break from a lot of medical care that some of these infants require after hospital discharge as well. And so because of this, we need to really think about, well, why is this important? Yes, this is a traumatic experience for families, but why shouldn't we just view that as separate? And the reason is because, and I'm preaching to the choir with this group here, is that family engagement, parental mental health, and infant health and development are all clustered together. We can't separate them from one another. So when families have challenges with engaging with their infant, engaging with their team, we see that this affects their interactions with the infant. They may misinterpret the infant's cues. Infants may have reduced language exposure, over or under stimulation. So engagement that isn't at a developmentally and medically appropriate level, may not be exposed to developmental activities at the right time frame when they're ready for it. And then this is also the highest risk group for maladaptive interactions with parents. So kids who are born preterm or with other medical complications are the #1 at-risk group for neglect and abuse in early childhood. And this also affects not just when they're home, but also the hospital course. And so it has serious implications for the cost to the hospitals to be treating these families. So those who are not engaged or may have some difficulties with mental health tend to have reduced visitation. They can have challenges engaging with their infant for cares, and this can prolong discharge readiness so that they have longer lengths of stay. We see reduced positive engagement interactions with the team and the infant, which can lead to burnout and just kind of challenges for the team working with these families. And then also these trauma symptoms can lead to just overall avoidance of engagement with the infant in other ways as well. And then again, after they go home, we continue to see this. So when parents have mental health difficulties, challenges bonding with the infant, we know that these infants get less language exposure over time. Less language exposure means less verbal development over time and can affect school and beyond. They may have decreased playfulness and gaze because they're not engaging as much with that infant. And so the infant isn't developing those necessary social skills at a very critical time period. Children born to parents with mental health challenges have increased behavioral difficulties, as well as are at increased likelihood for anxiety, depression, and other conditions themselves. As I mentioned, we can see more maternal and paternal hostility toward the infant. And then we can also see development of avoidant and anxious attachment styles. And in no way am I ever blaming a parent for these. This is what my point here is, that it's an interaction between some parental variables, but also the way that we kind of set up parents to engage with their infant and cope during this really traumatic experience. So that's where I wanted to talk about what our Connections program for high-risk infants and families does at our multiple locations, to talk about how we hope to kind of remedy some of these and really enhance the likelihood that both the family and the infant will have better outcomes. So at University of Colorado Hospital, we provide on-site services 5 days a week with our psychologists, and we provide antepartum consults, particularly to women and families who are admitted at 32 weeks or below, because we're starting to recognize that as an opportunity to start to prepare them for what may be a prolonged NICU course. We also do are part of the peri-viability consult team, and so helping families with that, kind of just coping as they're being faced with making some really challenging decisions if they are looking at delivering a very preterm infant. And then we do kind of general psychological interventions, which may include individual therapy for the families, and health behavior interventions as well. So affecting some of those health behaviors that may be manifesting in physical symptoms that require or that can exacerbate treatment. And then I also wanted to talk about, this is currently under research right now, and we are hoping that based on these really promising outcomes, that we can continue to explore the ability to do procedural preparation for women and families who are facing a cesarean delivery, especially when they have a high-risk maternal or fetal condition necessitating delivery. And so I wanted to just briefly talk about that, because we're very excited about that, and it's been a large focus for our research over the past couple of years. This involves a partnership between OB anesthesiology, psychology, and obstetrics and maternal fetal medicine. And we have developed have refined and are continuing to refine an exposure and psychoeducation-based intervention to prepare women and their partners. And please forgive me, I'm defaulting to women, but recognize that not everybody who delivers identifies as female or as a woman. But we work on bringing these families into the OR and really preparing them and walking them through the steps in the procedure for a cesarean delivery, while coupling it with very specific psychological interventions to kind of overlay that to help them so they don't become overwhelmed. And our goal is to help prepare them for delivery. So right now, this is in its second iteration of the study. So the data I'm showing here are from 20 women who are randomized to this intervention or care as usual at Children's Hospital Colorado. We have now partnered with 2 other hospitals to enroll 30 additional patients across 3 sites now, to look at how women who have been seen in a fetal care center and have a cesarean delivery respond to this intervention, looking at preoperative anxiety on the day of the delivery, postpartum state anxiety and trauma at 6 to 8 weeks post-delivery, as well as pain medication use prior to hospital discharge after they deliver. And are really excited about the outcomes that we've seen. We've seen a reduction in preoperative anxiety, as well as postpartum anxiety, and have also seen reduced oxycodone use starting at day 2 post-op, and that extends actually even to going home with medication. They had fewer pills that they end up taking home with them. So those are our prenatal and pregnancy services that we offer in integrated settings. We also offer services at the University of Colorado NICU, which is a 50-bed unit. And we see on average 25 to 28 patients are on our service at any time. So we tend to see, I'd say, about 15 to 16 consults per week, face-to-face or via telehealth, which we've started doing lately. And we automatically see infants and families who are under 32 weeks and then others by request. And we're starting to work on a protocol right now for addressing those families who are at about 32 to 34 weeks so that we can do some short interventions with them. So just to give an idea of the scope of what we've done in the past year, we had 681 encounters in the UC Health NICU with across 283 unduplicated patients. And that doesn't include the patients and families that we just did maternal mental health screening with in response to those. We do both systematic and individualized interventions, which I'll talk about, and then also participate in interprofessional rounds in collaboration with social work, psychology, and developmental health services. So the overall goals of our program are to reduce the parent likelihood of that trauma response. Again, we do view the NICU as a traumatic event for many families, but we do view that the way that they cope with that is malleable, and that's what we're really trying to do. So trying to enhance the opportunities for post-traumatic growth versus post-traumatic stress disorders. We also work on family team communication and encouraging the family to participate in shared decision-making. We increase we work with the family to understand their role and care of the infant, and I'll talk about how we do these a little more specifically. We encourage engagement in appropriate interactions with the infant, both for developmental skill promotion as well as state regulation, which we consider infant mental health, and then also to just generally support bonding and attachment between the infant and their caregivers. So these are just some general comments that we have received in the past few years as part of our survey. So the pie chart shows that 90% of families who respond to our surveys have said that they are moderately to extremely grateful for the services and would recommend to others. Some of the comments that came out were, I can't say enough great things about our experience. I found the support system incredibly rewarding and helpful for me every day. Our bedside sessions were so valuable to break down the NICU experience in real time, which I didn't understand how valuable that is for coping. It was validating to have someone acknowledge the hardship and emotional trauma of the NICU experience. The tools provided helped me manage the ups and downs and lack of sleep, emotional exhaustion a little better. And the psychologist's weekly visits were some of the highlights during my son's 7-week stay. She was encouraging, understanding, and empowering when we spoke, and I always felt refreshed afterward. So examples of just how kind of meeting with these families can help normalize the experience, help develop, give them some skills that they can use for coping with this, and kind of walk away feeling like, oh, I'm not carrying this all with me to kind of package and cope with once I go home. So we do a few different things in our services in the NICU. First of all, we do maternal mental health screening. We eventually would like to do paternal mental health screening as well. There are some just logistics related to charting related to that. So I have stuck with maternal mental health at this point in time for the formalized screening. We follow American Academy of Pediatrics time points, so 1, 2, 4, and 6 months, unless if we know that the family is already actively engaged in perinatal mental health services. So we're not going to screen for the purpose of sending them to services if we know that they're already receiving them. The way that we do this is our behavioral health team administers the screen, ideally in person, but we'll do it via telephone if we can't get a hold of the family in person. We score it immediately, so we make sure that there are no responses that indicate extreme depression or risk for suicide that are left unanswered. So we do score them and then triage immediately. We talk about the family, why we're doing this, why we score these, how we handle them. That has been very well received by patients. And so as an example, at our 1-month data, about 25% of women end up screening positive for depression and 5% indicated suicidality. So it's pretty low for suicidality, but we do see a lot of endorsed symptoms. We hope to eventually expand that to anxiety as well, because a lot of times the families in our NICU are experiencing more on the anxiety side of mental health rather than the depression side. And as needed, we provide referrals for outpatient supports with coordination of care. In addition, we, with most of our families, have been working on doing a dyadic intervention with them. And so that is an intervention that focuses on promoting parent-infant attachment and parent engagement with the infant in the NICU. And so I have this starred now because we've spent the last 2 years developing this and kind of working on the individual sessions one by one. Dr. Kelleher has been absolutely critical to this project, and so probably should be presenting this rather than me. So please jump in if I'm speaking of this inappropriately at all. And we just recently received a grant from Little Giraffe Foundation to systematically test what we have refined down to a 4-session protocol. Our goals are to teach parents, so to read and respond to their baby's cues, to understand that their interactions with the baby are critical, that they really do from day one have an important part in baby's care, and that they can start learning about baby's sensory awareness and development, again, right from day one. And then we work to coach parents to engage with their infant as parents and not just as kind of a medical staff. Often the families feel that much of what they do with their baby is so focused on the medical that they're missing some of those parenting pieces, and they're not sure how to engage with an infant and as a parent. And so that's what we really work on. And then we also work with them on developmentally appropriate activities as appropriate for the specific infant. So we have, as I said, it's 4 sessions. We have one focused on meeting baby's sensory needs. And each session focuses on a parent coping component, some education about the infant's development and how the parent can support that, and then a dyadic activity. So something that the parent can do for or with the infant in that session or in between sessions. So we have meeting baby's sensory needs. We do a mindfulness and co-regulation session, talk about setting routines with the baby, and then NICU footprint art. And each of these also talks about how we use these skills now as the baby is in the NICU, but then also looks forward and how do we use what we're learning during this session to really take forward and think about how we can kind of use some of these kind of course concepts to help parent this child over time. These are some preliminary data that we used in our grant application as we started rolling out these different sessions. So you'll see the number of families who we had data on, I guess about this time last year when we put in the grant. But what we found was that our meeting baby's sensory needs, parents had reported, again, these are small ends, but that they felt like there were actually things that they could do with their infant, even when the infant was very, very small. And many of them were on oscillators or still very, very tiny and just didn't really were not ready to feed, often could not even be held at that point in time. And parents also reported decreased level of stress at bedside when they engaged in that intervention. So these were pre-post questions. We asked the family for mindfulness and co-regulation. Parents trended to reporting that they felt like they were able to intentionally focus their attention for a brief amount of time. Often a trauma response and anxiety response means that we kind of have just really hard time concentrating, focusing, which then of course affects our ability to retain information and remember it. And so teaching the parents to kind of use mindfulness skills to focus for a little bit of time, we hope can help them process that information. And then also being able to calm oneself when feeling anxious or worried about the baby. For setting routines, we saw trends, again, small ends, in increased engagement in activities that the parent felt like they could do as a parent, and also an increased perception that they could actually influence aspects of the infant stage. So they felt like they had some efficacy as a parent in what was happening with the infant. And then for footprint art, we saw that they were saying they were able to read the infant's cues and also had more comfort reaching out to and touching the baby. Here were some quotes that parents gave about the individual sessions. So it helps me think about how to talk to him, to part with him, to say goodbye, calm down, and get ready for bed. This was specific to setting routines. It probably doesn't matter to the NICU baby, but it matters to parents. I'd also disagree that I think it does matter to the NICU baby, but I like all of it. Knowing that he could understand a routine was helpful because I didn't know that. It helps me feel like a real mom or real parent, and it helps me lead. It's so helpful when I have a new nurse because he still has us in our routine. And then I feel like I got to see the facial expressions and know my baby's cues and what he does and does not like. It was an excellent experiment. I got to learn about him with him together. Thank you for teaching me to notice this. I think that one was specific to footprint art. Okay, and then in addition to the individual level, we also think about how to improve care and enhance family engagement at a systems level. And our goals when we think about kind of systems level approaches in the NICU to improving care are to address disparities that we may see in family-based care, encourage trauma-informed care, and then collaborating with the team to support neurodevelopmental care. So I wanted to talk about specifically a project we're just wrapping up now, focusing on family engagement. And we looked at family engagement because obviously, as I've been talking about, it's incredibly important for the infant's hospital course as well as the family's well-being over time. But we also understand that family engagement relies on a few things that have to be happening in the NICU. So first of all, we need to make sure that we're creating and maintaining a learning environment. So there are so many opportunities to be teaching the parents about their child, and we need to make sure that we're maximizing these and often engaging the parent in those learning experiences, and not just when they're meeting with the physician in a family meeting, for example. Thinking about how we make sure that we really do value family-centered care, that we're not just visiting or considering parents as visitors in the NICU, but that is, they are really an essential component to the infant's care. Thinking about how we're addressing the emotional well-being of the family so that they can show up, they can process and retain information and engage with their infant, that we're promoting understanding of the infant's needs and behaviors, and that we're actually just encouraging parental presence in the NICU, that parents can actually walk in the door and be there. We know there are, on that last point, we know that there are disparities in this. So not all families can be in the NICU as much as others can. And so there's been some research that has shown that disparities in visitation do exist, and families attribute these to income differences, amount of travel time it takes to get to the NICU, whether there are other children at home. And then of course, there were several different hospital visitation policies, particularly during COVID, but of course during RSV season and other respiratory seasons as well. And this can be a problem. So disparities in visitation are not just about that the infant isn't having the opportunity to form an attachment to the family. It's also affects length of stay. And so here's some data from some baseline data for this project that we looked at. I think this had 75 or 80 families included in this sample. We looked at whether or not parents were present and engaged in nursing cares at least once a day, 4 days a week. So more days than not, but not expecting them to spend their entire day in the NICU. And when we looked at this, we found that infants who were born to mothers with Medicaid or uninsured status, so we were using that as a proxy for socioeconomic status, at birth had overall lower rates of participating in cares. And based on the last slide, we'd expect that because income and other variables that can make it difficult to come into the NICU. But what we found that was more concerning to us too was that this discrepancy increased over the length of stay, particularly around the 8-week point. So we had a discrepancy, as you can see, to start with about 68% of parents who had Medicaid coming in regularly, almost 85% of parents with commercial insurance. Those with commercial insurance are able to maintain that, whereas those with Medicaid are already start lower and then just kind of drop off over the course of how long the infant is in the NICU. And so I'll get to why that's important in a future slide. But also wanted to just touch base on, or to talk about, so we wanted to intervene for this. And so we wanted to do this by giving parents opportunities to engage with the infant, to have that learning environment, even when they couldn't be present in the NICU. And so we were able to purchase a series of iPads with generous funding from the University Hills Rotary Club during COVID, and use some additional funds to get stands that could lock for these, and have enough now that we are able to use these throughout the NICU for nurses and other care providers to pull into the room. They don't have to hold them. They have stands with arms that kind of reach over the infant. And so we can actually connect the parent to the infant, even if the parent isn't present in the NICU. And so we can use these for virtual care sessions, but we've also used these for our psychology intervention sessions, for developmental therapy sessions, and are available to any provider who wants to use them. We had several PDSA cycles. So what our goal was to increase the amount of cares that families were engaging in. So at first we started with the psychologists only using these to kind of figure out what are the workflows, how do we do this? lead by example, like figure out ways that we can do these. Then we started working with a small group of nurses and developmental therapists to start incorporating these into care for families who were not able to be at bedside, and then have expanded that over time with refined procedures. And so when it comes to those virtual care sessions for nurses and families and any other care session, we've developed some procedures and recommendations. So for these cares, the family arrives 5 minutes early, the nurse hops on when it's time, and they're only on for about 5 to 10 minutes. They do their cares, and what's really important is that they're talking to the baby and the family during this time and using it as a teaching experience. So a lot of times the nurses are like, what am I supposed to do with them? And we say, you do just what you do if they were in the room. You're trying to engage them and show, oh, hey, look what I saw in your baby. You notice that he's doing this, or here's what I'm looking for. So we're using that as a teaching session. And then when they're done, they say, okay, it's time to read to your baby or do some other routine that we've identified with them. We send parents home with a book so that they can do this. And the nurse can leave, the family can read this story to the baby or sing to them or pray with them. And then they sign off and the session has ended. And then we try to get feedback surveys. So it's very short. We have worked hard to kind of set the family expectations around that, but giving them this opportunity to make sure that this can also be part of their routine when they can't be present. And so here's what was really interesting to us. We actually did not see a difference from what we could tell from nursing flow sheets on parent presence or parent participation in cares 4 days a week or more during pre and post intervention. But what was really fascinating to us was when we started looking at the data for how participation related to length of stay, we saw some interesting findings. So in our baseline group, we looked at 51 families who we had full length of stay data for, so that they had been discharged, and looked at their visitation at 4 weeks. So when the infant was roughly 28 days of age. And we excluded any infant who was going to be discharged within 2 weeks, because we know as infants are getting ready for discharge, families are going to be there more often because they have to learn care. So we wanted to look and set at those who were having immediate discharge kind of pending. And what we found then was that parents who were there, or infants who had families who were there for 4 days or more for cares, had an average length of stay of about 80 days. Whereas those who had lengths of stay less, or had parents not coming in at least 4 days a week for cares, they had lengths of stay around 102 days. So a 23-day difference, which is really, really outstanding. After the intervention, what we found is the 75 families, we saw that difference go away. It came down to 3.83 days. I'll note that our standard deviations across these remain the same. So it wasn't that we had a few outliers in at baseline that skewed the data. And so we've been trying to figure out what this was. And what we started to realize is we weren't just doing the nursing cares. In fact, that was kind of problematic. It was hard for the nurses to do. But what we did was we had the opportunities for the families to engage in so many other ways throughout the day. Developmental therapies were bringing the iPads in and engaging that way. Our psychology team has been doing this a lot. We've seen nurses doing this at other times too. And so we think that that has potentially helped the families develop better relationships with their babies and with the team, and understand that their presence is important in the NICU, and so that they're coming in when they can and they're not avoiding as much as they were before. And so we're suspecting that may be related to those huge differences in length of stay, or those discrepancies in it. Okay, then we have our services outside of the NICU. We offer a number of different services. One is in an integrated clinic at Children's Hospital in our pulmonary hypoplasia multidisciplinary clinic, but then the other two services that I'm going to be talking more about, which are our perinatal mental health services and our child clinic services, are in our outpatient CU Medicine Psychiatry Clinic here on the Anschutz campus. Although we do say that we are on the Anschutz campus and we offer in-person visits, 90% of our visits still are via telehealth at the family's preferences, and we hope to continue to be able to do that as long as we're allowed to, for legal reasons, once the public health emergency ends in the next coming months. And we're still trying to figure out what that's going to mean for behavioral health services. But in terms of perinatal and family mental health services, we offer services to patients and partners with pregnancy or neonatal complications. And we really follow that. We are willing to work with them as long as the focus of the intervention is really on this experience of parenting a high-risk infant. And so we do see parents outside of the perinatal period, and we'll see them up to about when the infant's about 5 years of age, because we know that this course doesn't stop once they leave that 1 year point. That often for more of the complex infants, it can really be quite a significant journey, especially in the early years. We have, in the last fiscal year, we saw about almost 1,600 outpatient encounters, over 154 unduplicated patients. As I said, we offer individual therapy. We also have psychiatric medication consultation, and then group therapy models, specifically for fetal loss, high-risk pregnancies, and high-risk infants. This says after NICU discharge, but we've actually started doing it during NICU stay as well, which has been met with success. And I will note that because we've been able to, we've had enough funding to really grow our outpatient services, we have been very fortunate to have over 90% of our referrals start services within 14 days. And those who fall outside of that 14 days are often difficult to schedule because of the family's variables, or the infant is sick and they're kind of waiting on a few different things. I think we've had a couple that have been related to insurance, but most families, as soon as they're referred, we can get in very quickly. We also have our Child Connections Clinic. This has developmental testing along with parenting consultation. So it's a little different than kind of your traditional early intervention eligibility determination. We are doing full daily exams or WIPSI exams as the children get older to monitor their development over time and really talk with the parents about where are their strengths, where are their challenges, and what kinds of services might they need. We're also looking for any other kind of developmental and behavioral challenges that they may be presenting with during that time, especially since we know that children born preterm and with other medical complications do have a higher risk for behavioral difficulties and executive functioning challenges. And then we offer a brief parenting support interventions, again, specific to families with high-risk infants, which we deliver in about 4 to 6 session course of treatment. And we really focus on supporting the unique strengths and needs of that child, and then adopting strategies to support positive behaviors and interaction. Just wanted to note the importance of developmental assessment. So it is critical to monitor developmental functioning in early childhood, and often the screening measures that we use in general pediatric clinics are not sufficient for high-risk infants. They can often over-identify children, and they're relying on parent report. And so actually some previous research has found that you may as well flip a coin to determine whether or not a child needs further testing, because the validity and the psychometric properties of them for these high-risk infants are so low. So we do recommend that most children who are born with a complex medical condition or prematurity up to 35 weeks are followed by developmental specialists. And so we have set up a developmental assessment clinic so that we can be systematically gathering data on how these kids are doing to inform the family about needs for intervention, making sure the kids don't fall through the cracks, helping families identify how they can encourage the development of specific skills, and also then to inform neonatologists and providers about the interventions they do. That's another important reason for monitoring development over time. As I mentioned, we're using the gold standard in-person assessment right now, which is the Bayley-4 exam, and have also been working over the past 2 years to find appropriate telehealth versions of these. They aren't great, but trying to figure out how we can deliver such services to families who can't come in for clinic visits. And then we also have been working on, and next year will be a huge focus of what we do, our community engagement efforts. So we want to make sure that we're able to reach families, not just through direct service delivery. So we have been, we've got some generous funds from Newborn Hope to create a NICU parent resource guide and a NICU nurse resource guide that talk about how to deliver trauma-informed care and things that parents can do in the NICU when you don't have a psychologist there to actually be implementing some of the interventions that we do. And so we are wrapping that up. These will be available on our website. And if you contact us, we are happy to give you as many as you need to distribute in your NICUs if it would be helpful. We also have set up a community closet here on site where we have clothes that range from preemie to all the way up to 6 years of age. They're gently used. We've gone through them very, very carefully, washed them all, folded them all, so families can have appropriate, weather appropriate clothing for their infants if they're unable to obtain it for any reason. And then we've also partnered with others across the country, and then also created internally publicly available guides for families who and friends who are experiencing friends of families who are experiencing neonatal loss or long NICU stays. Okay. And our vision and our hope is to continue to expand these services to families across the state of Colorado through things like telehealth, through digital assessment, and through just ongoing referrals and hopefully expansion of where we're able to offer services. Right now here, this was from 2022. The blue are the counties in Colorado for families in which we've served. We hope to continue to expand that. To improve access, we do have a care coordinator who speaks with all new referrals. When families are sent over to us, we will reach out to them with family permission rather than expecting the family to kind of hold on to that phone number and remember to call us when it's convenient for them. If they give the provider permission, the provider will just send their number and we'll call them directly. For families who don't have great internet access, we have a free mobile hotspot program where we will send them a mobile hotspot and cover their data so they can meaningfully participate in telehealth. And then, as I said, we're continuing to work on the best way to do telehealth developmental assessments. And we'll continue to work on that over the next couple of years. And so wanted to this group to just briefly end with some different opportunities we have for collaboration. So anyone in Colorado can refer to our outpatient services. So we can do our perinatal clinic, they can refer their child's clinic, and also can talk about the families about the importance of developmental follow-up and send them over. We are actually scheduling the University of Colorado Hospital NICU infants right around the time of discharge and giving them a date for a year out. We call them a few months beforehand and say, hey, is this still a good time? But that way, at least they have something kind of in the books, and we've started to talk to them about monitoring development quite early. We're also hoping to, we have applied for a grant and hoping that these funds will come through to pilot telehealth version of what we do to a few NICUs in the state. And then we are, we also have these resources that I showed on the previous slide. And so anyone can take those and distribute them to families in their NICUs as they like. And then our goal for this next year is to start finding some community organizations with whom we can partner to make sure that we're able to showcase their services and connect our families with them as appropriate, and vice versa. And then just wanted to say thank you to our many funders and partners who have helped stand up these services, and of course to our fantastic team. And this QR code is for our website that has all of our referral information and contact information, should you have any questions. Thank you.
Thank you so much. That was incredible. I think I've heard parts of it over the past couple of years, but to see it all in this one presentation, the scope is so large, and you are impacting such a large population of high-risk infants and their families. It's really, really incredible. Let's open it up for questions. Feel free to unmute yourself or chat in, and I can get us started. The first question that I had is for infants who screen positive for developmental delay or risk and or are evaluated through Bayley's and needs are identified, what comes next? Does your group, are you also charged with the provision of therapy or other services to support their development?
Great question. Sometimes yes, and sometimes no. So and Jessalyn and I were debating whether to include this slide yesterday. We had a slide of like our 5 most recent patients and what the recommendations were and what we did with them. So I'm trying to recall from memory, and Jessalyn, jump in if you recall, but there, I think there were 2 out of the 5 of the last ones we had actually did require some parental child behavioral therapy services. So the child had a lot of dysregulation and the parent wasn't sure how to manage those. So we did some work related to that. Another was a Spanish speaking family who was having a really hard time connecting with services. I think they'd had EI and then they moved and were dropped from services and weren't able to connect. So we worked with our care coordinator to set them up with appropriate services for them and their family. So sometimes we're doing the care coordination. sometimes we may be doing an aspect of their care. And then we are really interested in, and our partners over at University of Colorado Hospital in developmental therapies are also really interested in partnering and getting their therapists into our clinic. It's just logistically challenging because they're University of Colorado Health employees and we're University of Colorado employees in our CU Medicine clinic. And so how we can actually partner for those services. And then we're also working with Children's Hospital, and hopefully they will also be setting up a neonatal follow-up clinic. And so trying to kind of streamline those so we can provide all of those various services at one site instead of having to like work on referring out as need be.
Other questions? Well, let's talk funding and sustainability. There is a wide array of services that you're providing in different settings, and wondering what sustainability looks like, and as well as reimbursement.
Fantastic questions. So a large proportion of our funding comes from HCPF, so Colorado Healthcare Policy and Finance Committee, to support Colorado Medicaid recipients. So we have been very lucky to receive that funding, but are also expected to eventually have a sustainability plan. And so those are the pieces we're working on. What has been unfortunate is the services for infants in NICU require billing what we call health behavior codes. So we obviously can't provide psychological services and build psychotherapy codes because these infants aren't depressed. They don't have a mental health diagnosis that we would attach to it. So there are what we call health behavior codes that can be used by psychologists, which are for health interventions to improve the outcomes of the infants. Colorado Medicaid has not opened up those codes in our state, though they're open in more states and not across the country. And so that's been a real hardship to make the inpatient services sustainable, which is unfortunate. And so most hospitals that have NICUs are supported by, or that have NICUs are now starting to buy psychologist time because they see the value of that. We do not have that in our hospitals right now. So we are hoping that over time we will have ongoing support from the hospitals to maintain these services should our funding go away. And then in outpatient, we do bill. And again, mental health reimbursement is not great. It does not, we do not break even. So we do rely on a lot of funding for the, or external funding for these services, but we are able to offset a lot of our salary costs and personnel costs through that direct billing.
I don't know if there are folks that work in the policy arena on this call, but it seems like, at least with respect to inpatient reimbursements, that certainly seems like something we should think about in the legislative arena. You know, what codes can we open up that's that in fact can be reimbursed? Other questions?
Hi, my name's Cheryl Caparola. I'm actually one of the cardiac intensivists over at Children's. Very interested in neurodevelopment and particularly parental mental health. And I was interested in how you screen the parents for depression. And I know you want to do anxiety, but because I would love to do that in our CICU. And one of my questions is, or one of the difficulties for us would be screening parents who don't have charts at Children's. Are you able to do that because the parents had been seen there, or are you able to document it in a way that it doesn't go on a parent chart?
That is a great question. And there are many debates about this across the country, including for pediatric screening. So many are in pediatric wellness clinics. And Jessalyn, if I'm talking too much, you just jump on in too. Sorry. In our NICU for ease, what we document in the baby's chart is that the parent was screened. And if they screened, it says, I think, like if the parent screened positive, appropriate resources were given. Mm-hmm. And then we document in the parent's chart, which has been a luxury for us because most of the parents have a chart. If they do not have a chart, so if the baby maybe was transferred in or they were for some reason or other, the mother does not, we only create a chart if they screened positive. That was something that we struggled with at Children's Hospital when I was over there about how to handle that, because it takes a lot to create a chart for everyone to document there. And arguments are that honestly, this is relevant to the baby's care and it should be in the chart. And AAP and some of their statements have, or I don't know if an AAP formal statement has come out, but statements and position papers that have come out about screening have encouraged documentation in the chart. I think there are still risks if you're putting parent information in a chart, especially if you're only doing it for the mother. Should there come up any custody issues in the future? And so I think if we do that, I do think it needs to maybe be a confidential note or a way that it's not easily accessed by both parents should any sort of issues come up in the future. And there is stigma still, unfortunately, against parental mental health. And so it also requires a lot of work with nurses to understand that, because I've heard, and not necessarily in the NICU we're in, but in NICUs in the past, like, oh, that mom's depressed, she's even taking medication. And this idea that then when the parent brings in concerns, that it's kind of dismissed or viewed in a different lens. And so there's also those pieces that have to be considered with who's seeing that documentation and why and how are they using it. Jessalyn, do you have anything to add?
No, I think I was ready to jump in, but I think you covered all of that.
Thank you.
Your questions? Can you talk a little bit about what developmental screening, identification, and then provision of appropriate therapy looks like for families in rural areas? You know, I think for us in the NICU, we've looked into some work that was done in Boston where you think about parent-reported, developmental screening measures, some telehealth, but I think we still are not as familiar with the landscape, with the research landscape and how robust those are. But it just feels like, given our broad catchment area, that's the direction we almost have to go to if we want to ensure that our rural communities are included.
Yeah, I think so. The purpose of screening is to determine if somebody needs further evaluation and services. So it's pretty clear from, a couple decades of research now that infants, even infants born with any medical complexity, but particularly prematurity up to 35 weeks, are at risk. So in some ways, screening is not as necessary because we already know they're at risk. And so the purpose of the screening tool isn't really needed. We should just be referring and systematically following. The problem with parent report measures is that they just are not accurate for high-risk infants, the way that they're often given. So two of the main measures, both the ASQ, the Ages and Stages questionnaire, and the PEDS, are technically supposed to have materials that are also being used with them for the parent to screen. So you're supposed to have a piece of string available and some blocks available, because oftentimes the actual questions that are being asked, the parent may never have seen or not have given the child the opportunity. So you're supposed to send it to the parent, give them a bunch of toys and tell them what they're supposed to do to try to observe this and then report it. That's not what works. Instead, you're given the screening measure if the place is screening when they're in the waiting room and they're quickly trying to, respond to it while also juggling maybe a 2-year-old who's running around the room trying to touch everything, which is causing the parent a lot of anxiety anyway. And so you're not actually getting a valid screen, which is unfortunate. So my thought is we should be at least doing a full assessment on every kid, and if not in person, doing an actual even short direct assessment with a psychologist or other developmental specialists online, so that somebody is laying eyes on the child and really even in that parent interview asking, well, what do they do? Well, tell me more about what they're doing. How do you know that they're doing this? Because I've had parents of a 2-year-old say, oh yeah, he can cook dinner. And I'm like, no, he can't. But, or, saying, oh, he can totally walk. And the child clearly, can barely hold on to something, but whatever the parent is really hoping and thinking that they're seeing is not actually what we're asking in this question.
Other questions? All right. Oh,
I have a
Emily.
question. Um, thank you, Allison, so much, and thank you guys. I was wondering if you could just speak to, I know you're saying like screeners for parental mental health aren't necessarily helpful, but I often think about the fact that like the way if you have a parent who is, brings home a term baby who is, anxious or depressed to the point of not, like they're not functional in their daily life because they're fearing for their child's life, who maybe doesn't have any medical reason for the parent to be afraid, like that, this kind of like irrational fear that their baby's going to stop breathing that you might see with a mom who brings home a term baby versus a parent in the NICU who is having those same fears, but they're not irrational fears. Like, to me, it's like those are different things, right? Like and so, but both need attention, but maybe in different ways. Like, I think it's safe to say like all parents going to the NICU are probably experiencing some form of trauma that is going to impact them. And so it's like, how do you decide, how do you navigate that in deciding like what is irrational versus what is not, versus like, does it all still need to be treated type of, is that making any sense?
Yeah, and I'll bump that to Jesselyn, but I want to clarify, I actually think screening is very important. So I think maternal mental health screening and paternal mental health screening is very important, and interpretation and context, which is why we do them in person. But I'll let Jesselyn answer that one, how we kind of differentiate those two as well.
Yeah, I was going to say, I think, you're very right. When you've already kind of watched your baby have many medical events and, Brady's and apneic events and all of that. And then you're like, okay, I'm going to take this baby home. I know at the university, we have like the 5-day, event-free window. And many parents are like, what if he has this event at home? So you're right. It is not irrational. It's something that a family has been through and seen and lived through. And I think, honestly, the first step is really acknowledging that, because sometimes families really will say, I feel like I'm going crazy. Like, why am I worried about this? And I feel like I'm going crazy. And to really just say, like, absolutely not. You're not going crazy. So I think it's more about how do you learn to cope with the environment and kind of your baby's behaviors and what's going on in the moment, and really kind of bringing that like present oriented kind of view, while acknowledging that everything you've just been through in the past weeks and months is impacting that. I don't know if I'm saying this very well, but essentially really working on like coping in the moment strategies while validating everything that's been leading up to this point. I don't know. Yeah. What I would kind of say. And it really just validating that, like, of course you're scared, of course you're nervous. I think we often have this conversation. Again, I agree with Allison that screening is really important, but our screening tools aren't necessarily the greatest for NICU families. We do a lot of screening in the university, and I almost always have a mom tell me, like, the question is something about, I feel scared or anxious for no good reason. And we talk with families about, like, you have a million good reasons to feel scared or anxious. And so I think the screener itself, and hopefully sort of all of mental health care, is about really the conversation about the numbers more so than the number itself, right? Like really helping families identify, sometimes seeing the numbers for families actually can be really helpful. Like, wow, I didn't realize I would score so high. And what does that mean? And how does that kind of make sense in the way I think about how I'm coping? But again, I think it's that conversation more than anything that's really critical.
We had done a series of focus groups as we started preparing those newborn hope or those guides. We call them our newborn hope guides because they are the ones who funded that work, but our newborn hope guides for families and NICUs. And one of the things that families kept saying to us was, we want people to be talking with us early on about mental health. Like, we may not even know that we have symptoms right now in the NICU, but we want to have those conversations. We want people to say, it's okay if you don't feel too attached to your baby, or you don't feel like the parent of the baby right now. And so we really view the EPDS, when done right, you can't just like have a nurse hand it to them and say, fill this out and walk away, but using it, as Jesselyn said, as a conversation with the family and saying, like, here's why we screen, here's what we're looking for. Validating, normalizing, and also saying, and just because this is a normal reaction, doesn't mean there isn't something we can do about it. And so it's a jumping off point for a really serious conversation with them too.
I love that because I think that part is so important. I think because I'm an NICU parent and I feel like, you know, like, well, yeah, I am sad all the time. Yeah, I am scared to death all the time. Like, but isn't that appropriate? Kind of. So I think that was my take on it, where it's like having someone say like, and you know, there's still a lot we can help you with. Like, especially afterward, I'd say when you like realize the trauma, your own trauma and the trauma of the parents that you don't even know around you, I think that's like some of the hardest things still that I, you know, 3.5 years out, like remembering the things that didn't even happen in our room. So, and like, that's not what I would have thought, you know, like going when I started my journey. So I think that's awesome. I think the emphasizing the conversation is awesome. Thank you guys.
Thank
All
you.
right, well, it looks like we are just 1 minute past the hour. Thank you again so much, Allison and Jesslyn, and we look forward to seeing you all again at the next quarterly webinar series. Thank you, everyone, and have a great afternoon.